Thanks everybody for joining. We have two great speakers, which is why we have so many people, I think, joining the webinar today from different areas. We have children's hospitals, academic medical centers, community medical centers. We have people from the US, UK, Australia, and as far away as Saudi Arabia as well. So thanks everyone for joining. A few housekeeping items. We'll have QA at the end, so if you send your questions into the chat in a circuitous way, it will get its way to me, and I'll make sure that we have the questions answered. If we don't answer all the questions during the webinar, we are going to put out a blog post that summarizes what we talked about next week, as well as the answers to any questions that were asked on the webinar.
Are we making the slides available to the attendees?
If you like, for sure.
Yeah, because there's some slides that have a lot of verbosity on them. I'm not going to go into detail, but it'd be good to have people have that to refer back to.
Sure, absolutely. But we are very pleased to have Dr. Rab and Dr. Patty with us today to talk about a topic that's on the mind of a lot of clinicians when they use an EHR application when caring for their patients. Because it causes frustration, but it remains a really challenging topic to quantify, understand, and solve. And what I'm referring to is EHR speed and reliability. What we'll discuss today is departing and how these two doctors have been able to depart from the traditional mindset of thinking that when clinicians experience EHR performance issues around speed and reliability, that they're the responsibility of the IT department to solve or the vendor, and that clinicians' feedback is merely subjective perception. EHR speed and reliability issues are digital issues, and therefore they can be isolated, documented, and resolved. The first step to that is mission alignment between the IT side of the house and the clinical side of the house, with a common set of facts on which to build productive conversations. Today, we have Dr. Shafiq Rab, who is a doctor from the IT side of the house. Dr. Shafiq Rab has run transformational IT organizations throughout his career. And as he said the other day in a conversation, his goal in part is to bring the joy back to practicing medicine by keeping technology as an enabler of that as opposed to an impediment or a challenge. Incidentally, he was also, I believe, Dr. Rab, if I recall, the first CIO to move an Epic instance or an EHR instance to the public cloud, so always on the leading edge. Dr. Patty is also with us today. In his various leadership roles, he's actually been a visionary in terms of improving clinician experience in a number of ways. In fact, what we all talk about today is this EHR house of success, and in fact, he's the architect of the original EHR house of success. And in both cases, these doctors have greatly contributed to the healthcare community, ultimately impacting the quality of care patients receive and the satisfaction of clinicians. So maybe I thought Dr. Patty and Dr. Rab maybe kick off by talking about how you all met, because I think it lends itself to the overall story that we're going to tell today.
Yeah, it's actually kind of a humorous story because, you know, Shafiq and I have known each other for many years, but when I was at Rush, we had a CIO retire, and there was a search for CIOs, and they brought in multiple people, and Shafiq was one of them. And I remember after everybody had done their interviews, the COO of the organization grabbed me in the hallway and said, you know, who's your preference? And I said, look, you got to go with Dr. Rab. I mean, there's no question in my mind. And he said to me, do you think you'll fit in with our culture here? And I said, no, and that's why you need him. Oh. So yeah, Shafiq and I spent a number of years together at Rush and really refined some of the stuff that we're going to talk about today. Refined our approach to the stuff we're going to talk about today there.
I remember calling Brian on a call, Dr. Patty. I've never met him, but I've heard of him. One of my bosses when I was at Orange Regional, which is now known as Granite Health, the CEO, he had worked at Health East, and he knew Brian Patty, Dr. Patty. I really enjoyed working with him. The only skill set that I don't have that he has is that he's an emergency physician and an ambulance driver. So just to let you know, he can drive really fast. And he knows the roads, pretty sharp guy. Sometimes his office and my office was next to each other. So sometimes I would sneak into his office and drink his espresso. Dr. Patty is a very fancy person, you know, like operating high class.
I always had to have an espresso machine because I like my coffee the way I like it, right? So one of the things that, let's see, my slide advancing isn't working here. Why is that? There we go. Okay. I'm going to talk a little bit about burnout. Because I really think that is one of the key drivers as to why organizations are trying to improve EHR efficiency. And these are obviously statistics from the US, but burnout's an issue everywhere. It tends to be less in non-US EHRs because there isn't all the regulatory requirements, but it's an issue everywhere. And quite frankly, the more burned out physicians are, the more likely they are to leave the organization, causing turnover and causing expense to the organization. Mayo Clinic Proceedings monitors this with their surveys. AMA published an article in Mayo Clinic Proceedings actually just 2 months ago in July. Looking at the recent statistics, and as you can see, we really have done a great job of impacting burnout over the last 10 years. It peaked during the pandemic, it's come down somewhat, but we're still at pre-pandemic levels of burnout. And so it's still a driving issue for organizations as we start to see physician shortages. It's an issue for nurses as well, but my expertise obviously is on the physician side. I compiled this list of kind of some key tasks that organizations can use in addressing burnout. From assessing the level, measurements is key. Measurements in any area, whether you're measuring burnout or measuring EHR satisfaction, you have to measure so you have some data to start with and some data to compare when you remeasure to see if you're making improvement. So I'm a big fan of measurement. Assessing that level of burnout through measurement, and then looking at things like optimizing the care model, enhancing clinical workforce management, decreasing administrative burden, increasing clinical efficiency, improving clinical and leadership alignment, and providing comprehensive well-being support. I put this up here because really 6 of these 7 are impacted directly by a properly designed EHR satisfaction program. And one more key fact I want to kind of throw in there before we talk about the House of Success and building a program. This is the most recent impact report from ClassArch Collaborative on burnout. One of their key findings is it's easier to prevent burnout by increasing EHR efficiency early on than it is to reduce burnout when it's already peaked. And so taking a proactive, programmatic approach is what I really recommend for organizations. Don't play whack-a-mole. Don't see an issue, attack it. Develop a program at your organization to really address all of the key factors that impact EHR satisfaction and apply that programmatic approach proactively. And so you're attacking these issues ahead of time before they start, because it's easier, as the class found out, much easier to impact burnout with a proactive approach than a reactive approach. So while I was at Health East, I got a lot of lean training. I think my mentor Didier Rubino, he was our lean sensei, and he kind of drove home the the programmatic approach that I've taken ever since I've been there. I refined this while I was at Rush and working with class. I think class still uses a similar house of EHR satisfaction. But really, there's kind of 4 key elements in an EHR satisfaction program. The base and the foundation, what we're going to focus on here today, is EHR speed and reliability. As you know, with any house, keeping this house healthy, if the foundation of the house isn't solid, nothing else matters. You can have the best architecture above that foundation in the world, but if the foundation is faulty, the rest of the house is not going to be sound. And so, while I really encourage organizations to look at training, education support, governance, and personalization, those things are not going to be as effective if you don't solve the speed and reliability issues. So this is the slide that's a little verbose. I'm not going to go into all of this, but it kind of goes into a little more detail in that foundation and the and those 3 key pillars, the EHR satisfaction. But again, as I mentioned today, we're really going to focus on that foundation, because that really, if you don't nail that, nothing else really matters. And that foundation is around EHR speed and reliability. And a couple of key points here. One, keeping up on the latest functionality of your EHR. The EHR upgrades happen for a reason. It's because the vendors, they're trying to keep up with the latest and greatest, improving workflow and improving speed and reliability. Voice and AI are also key elements to keep up on. You hear a lot about that in the press today, but quite frankly, it is, we're seeing some really good data that it's improving EHR satisfaction in many areas around documentation, improving workflow, automating tasks, even getting into, going from generative AI in the documentation piece to agentic AI in patient satisfaction and clinician satisfaction. So keep abreast of where AI is going and where it's the most effective, because I think that that's an important thing. And then, quite frankly, we're improving that base speed and reliability, knowing where your issues are. I know when I got to Rush, I was seeing login times of 45 seconds or more, but nobody was complaining about them. And I asked them why, and they said, well, that's just the way it is, isn't it? And I said, no, it should be like 4 or 5 seconds. So, and so knowing what your issues are and where your issues are really important. And we'll talk about the importance of monitoring. You can't rely on tickets because if the issues have been around long enough, or people don't even know it's an issue, you're not going to see it in your ticket volume. And so having tools, like Goliath, to monitor your speed and reliability and understanding those, getting to those root issues. That was another key thing that lean management drove to me. You have to understand what your root issues are. You can see a problem that may not be the root issue that you need to address. You have to drive, you have to continue asking why, and you have to monitor, and you have to get to those root causes if you're really going to solve the issues that you're having. So one of the things, Shafiq was talking about, our offices were right next to each other, and we worked together to solve a lot of these issues. It was really a hand-in-hand approach of the clinical team and the IT team, really looking to solve together the issues that were impacting EHR satisfaction at our organization that we worked at together. And some of the challenges that we see are are how do you quantify the size and impact of speed and reliability issues at your organization? How do you understand how often and for how long those issues have been persisting? And how do you really get at the root cause? Oftentimes, everybody says, oh, get a call from the on your ticket line and saying, well, the EHR is slow. Okay, what's causing that slowness? How do you get to those root issues, those root causes? And so we're going to spend most of our time, Shafiq, I'd love to hear your comments on what I've said so far, and some comments on some of this items on this slide.
Can you hear me, Dr. Patty?
Absolutely.
Thank you. So, we are all looking forward to the world of AI, and the rate limiting factor for AI is GPU, and the rate limiting factor for GPU is data center, and the rate limiting factor for data center is power, electricity. No different in a health system. I think what has happened to us that we're talking about AI, we're talking about generative AI, multimodal AI, we are talking about lake house. Those are phenomenal things, like you said on the top. We're talking about electronic health records. We're talking about lickety split access on mobility, on iPhone, on iPad, on other laptops, and all those things. We're talking about all those things. Some are new, some are old. The thing that you brought up today is something going back to basics. Why it is important, and the comment that you made, the house of cards, or as you call it, the house of the EHR ability, is the following. Doctors and nurses and clinicians are people who have given their life to serve. And they did that before EHRs, they will do that after EHRs. They will always take care of the patient, they'll find a way of doing things. It's not that the doctors and nurses are going to wait for a click to happen. And they do that. They put their heart, their mind, their life in it. For us, the important thing is people are listening to us. Here's the thing that I'm going to say in a sequence, and then we will talk more in detail. Number one thing, in any place we go or anywhere we work, collaboration is very important. Mm-hmm. Collaboration among your own team, collaboration with the people who work there. Like you talked about lean, you have to go to the Gemba. That means people need to round and people need to see with their eyes. I get that. But technology has improved and time and speed has improved. Physical inspection does help, but you need tools that tells you that this individual on computer number 33 is spending 6 seconds for an icon. That technology is available today. It's not that it's not there. And you can run a Gen AI tool on it, and you can know every day which area is slow and which area is fast. And by individual person, you can do that. So going to the Gemba is important, but using tool is important. But none of this will happen until unless you realize you're part of a team. Mm-hmm. A team alone cannot do anything. Clinical team needs our help. So does the CMIO, and so does the COO, so does the CMO. So what does that mean? That means we have to have some kind of a governance. Mm-hmm. On the top, middle, bottom, so that we all talk about it collectively. It's not a blame game. It's a place where we are here to make things better. So start with governance. Second, identify the problem. So when you identify the problem, the funny thing that you said are two things. One, you said we rely on ticket. If you don't get a ticket, there is no problem. That is not correct. There is problem. Second thing you said is that people stop complaining. Why? Because they get used to it. So that does not mean that the problem doesn't exist. So we have to find different ways of getting that input. But we are technology people. We should know before the problem happens. We should anticipate. Today you can tell which server, which GPU, which CPU is going to die when. We know that. We have that technology. It's not that we don't. So second is that when you start your processing technology, you get an ISP that provides internet connection to you, or the power comes in. Get two of them. Don't get one, so that you have redundancy. In the clinics, when we give access to clinics, you should have two types of sources that come there. If one fails, cellular picks it up, so that there is no stoppage of work. Second, make sure your firewalls, your group policies, they are all in alignment. But when you make a change, that means you're updating Microsoft, you are putting a patch in. The governance committee helps you create a change management committee. That helps you with communication. The clinicians are your friends. They are part of you. Explain what time, when, how that happens makes things better, right? So first is the assessment that do you really have the infrastructure, the routers, the switches, the controllers, the laptops, the Windows 10, Windows 11, the latest VDI, the Citrix, the load balancers, are they all up to date? If not, we'll have to work on it. Second, there are blind spots in the hospitals, especially in the area where we do radiology. And there are places that other things happen. So or if you have research, instruments get affected by that. So your knowledge will increase, governance, infrastructure, get to know the problem before it occurs. And then as you are going through the list, figure out a way to communicate. And one of the things that I have learned over my career, I'm not very good at it, I'm still working on it. If you have to communicate 7 times, 14 times, because the human brain, the way it works, the neurons give the charges out to the dendrites, but the way the human brain works, we need the same information at repeated intervals. That's how we remember things. So the thing is, before it happens, if you can prevent it, great. If not, get a project behind it. And that project, what it does, if the devices are right, if the iPads are right, if the iPhones are right, if the application is right, network is right, redundancy is there, and if there is a disruption, people know that. What that does, it builds the trust between you and the clinicians. And it builds a trust between me and Rab and Patty. Rab and Patty was my friend and ally in the next door, even though we stole his Nespresso, as I told you. Now that you have to make it, you have to pay him back. But the thing that we talk about is that we talk openly. The word is transparency. The word is being fair, right? So problems can only be solved if we are transparent about it and collectively think. Because when do we talk about all of this? We talk about during budget session. We talk it about during capital budget, operational budget. So money allocation happens. And why are we doing this? One of the advice for the people who are listening to us, in the world that we live today, do not do anything that does not have an ROI. That means you need to have 3 to 4 times ROI. So let me give you the example. If you want to increase the physician productivity from 30% to 60%, and there is no delay, the productivity goes out, the RVU goes up, and the access to care goes up, and you see more patients. So you really have to have 2 types of ROI, hard ROI and soft ROI. But what you cannot beat, and it is priceless, and the priceless part is the clinician satisfaction. Because believe me, we are all patients, we need them one day. So please be in the good books.
You know, and Shafiq, you make a good point. And, you know, quite frankly, ROI is different at different organizations. And so part of that communication and governance process is understanding what's important to your organization. What's the ROI that they're looking at? Is it hard dollars? Is it efficiency? Is it patient satisfaction? what is it you're trying to achieve for that ROI at your organization? What is it that's going to be paid attention to by the people that hold the purse strings? So yeah, I agree. Finding that ROI, sometimes it's hard dollars, sometimes it's softer, but understanding what's important to be measuring and reporting on, not just measuring, but reporting on at your organization.
I think, Brian, you have hit it on the nail. And the part that what you are saying to me in a different way, hey, Shafiq, become smarter. Smarter means that we are now living in the age of AI. Whether it is multimodal AI, whether it is agentic AI, all these tools are available for IT to predetermine, to understand their infrastructure, to understand their cloud infrastructure, the speed, the reliability, what is needed where, what the storage will be less. So the olden days of just walking, relying on ticket, or relying on tools are gone. We have to evolve as an IT team. We have to evolve to use this next generation tool that makes the lives of the clinician better. The use of AI is not only for denial management. It is also used for cybersecurity, and it's also used for devices, where they are, who's using it, how much it is being used, when it is going to die, when it's going to be replaced. Imagine you are an ED physician and you are logging in. I know that your device will not work 3 seconds from today, from that time. And somebody comes and swaps the device even before you log in. You're like, how'd you know? Well, we can't say that we know everything. So the use of newer technology to establish clinician digital experience is our new quest for IT infrastructure people. That means we have to up our game.
Dr. Rab and Dr. Patty, when you all started to work together and you encountered each other by the espresso machine, did you have a sort of a can you frame up what maybe the top 3 issues were? My sense is from talking to you that there was a problem with clinician experience complaints and things like that. Do you have a top 3 or 5 things that you sort of identified in your conversations when you started talking to each other?
Yeah, Dr. Patty is a very structured person. I can tell you how the conversation started. Class had started or not started at that time, Arts Collaborative. And we knew that the burnout was an issue. Our CEO, our COO, our presidents, they are incredible people. When I worked with them, they were all thinking about it. We even had a doctor who you can go to and talk to about your problems, right? So Brian and I talked about it. It's not that we did not. And we didn't have this nice slide that you are seeing today. Dr. Patty built it and went through a process to formalize it. But the 3 problems that you are saying to us, we knew that things were slow, at least. And we knew that there is a physician burnout. That was our most important thing among ourselves. Hey, how do we decrease clinician burnout? That was the topic we are talking. And then from there, Dr. Patty took it upon himself, started designing, and like you see all this phenomenal. He's a faculty, and he thinks that way to organize things, and he worked with class. And as you will see at the end of the slide, the fruit of the result. So the 3 problems that you are saying, first, the thing that he mentioned, some of us didn't even know what the login time should be. Right? So it's not that the institution was bad or good. The institution was always good. People are doing it. We just didn't know. We also didn't know the enormity of the changes that we had to make. So we were not even aware of that. So that's the second thing. First, we wanted to take care of the burnout. Second, we didn't know how big the problem is and where it is. Third, we had to plan for it. It's not like the money grows on a tree and you just go do whatever you feel like. You have to plan for it, and then we have to get help. This is the governance committee, and get the people's opinion and get ourselves organized. So organizing ourselves, just because IT thinks they can do whatever they want, it doesn't work that way. In the real world, we are a service department. The operational people, the clinicians, and the customers, they are the real people, and we are the fourth part of the quadrant. People used to call it dyad, triad. I have a new terminology, I call it a quadrant. That means the clinician, the operational people, the customers, which could be the patient, other people, and the fourth is IT. We started doing, last part I'll tell you, we did rounding. That means when the resident will be there, the nursing student will be there, the pharmacy person will be there, and an IT guy. Think about it. We did rounding like that. So, because if there's a problem, we solve right there. So that is the initial meeting between me and Dr. Patty. Now, Dr. Patty will talk in a very extraordinary way, so that the way he talks. So go ahead, Dr.
Yeah, I mean, I think that the House of Reliability or of EHR satisfaction that you're seeing here really addresses the four things that we really saw were the issues: speed and reliability, training, education, and support, governance and communication, and personalization. And time and time again, every organization that I work with, and I work with a lot of organizations, these are the issues that they need to resolve. And that's why I say, you have to take a programmatic approach. You're going to see these things continue to come up unless you address them proactively. And Shafiq was talking a lot about governance, and that's so huge. And governance is a two-way street. It's both about listening and about educating and communicating. And so you get good feedback from a good governance structure. But I always say at the end of every governance meeting, save 5 minutes at the end of the meeting to say, what did we decide on here today, and how are we going to communicate that to the organization? Because if, you need to continue to have that constant, 7 times 7 ways, right, of communication that Shafiq talked about, and you need to understand what is it we're going to communicate, how are we going to communicate it, and who do we need to communicate it to. That should be at the end of every governance meeting is that communication strategy. And it might be through multiple modalities. It might be a different message to different groups, but you need to understand that communication piece. So governance is both about listening, but it's also about communicating. And so I always love to drive that home. And that's how you understand what your problems are. That's how you understand how to best solve the problem for the organization. Shafiq, comments on that?
I think very nicely said. I think also in the governance process, as you go layer by layer, make sure that different types of leaders, emerging leaders, and other people are also involved in it, because you just can't be the CIO is the governance. It doesn't work that way.
Yeah.
So you're right. At the end, that was a pretty neat idea. That at the end, for 5 minutes, hey, what did we decide? What did we learn? And each member of the governance committee, as you go there, at the bottom is the working committee, top, each one has an accountability. That means come and share. So it's not that you're part of the governance committee and you just listen to what we have to say. So it's a two-way street. Everybody has a role to play, because it's our institution that we are trying to make it better. And it will only be better if you work collectively and if you listen to each other and understand it and try to solve it.
When we're working with health systems, we see a lot of times a gap between the perception or their reality the clinicians have and what IT thinks are the issues. And when you end up getting the CMIO and the CIO together in the same room and they have agreement, then on let's say a plan, talking about governance and communication, there are so many layers below you where the actual operational execution has to occur. In your experiences, how have you been able to communicate that down? Because there must be, even in our recent experience, situations where executives from both ends, clinical and IT executives will agree on a path forward, and there's, passive aggressiveness, sometimes overt pushback from the various groups. How, in your past experience working together, did you ensure operational execution of the ideas that you all put in place at the executive level?
Well, I think
go ahead, Brian.
I think first and foremost, it's speaking with data. You have to have some data to back up what you're saying. And that's why I love to use the ClassArch Collaborative Survey to show exactly where our issues are, but also measurement tools that show you here's where the issues are, here's where the root causes are, and then you can go back and say, after you've applied what you think is the solution, you can remeasure and see, did I actually solve that problem? And so I think measurement is, data and measurement is key. I always take a data-driven approach. I always try to take an evidence-based approach, and then telling stories. Stories are so critical. When you come in and yes, data is important, but then have a personal story that goes along with that data to drive that point home of, here is, when I was trying to get more resources for training, I told a story about an orthopedic surgeon who was just resistant to getting training. Everybody knew who he was. I was at an organization, and he was a big voice at the organization. Everybody knew who he was, and everybody knew he liked to complain a lot. But we finally got him in for some additional EHR training because he was complaining about how terrible the EHR was. And it turned him around. He turned into one of our biggest advocates because he really said that 1 hour of training, I get back 2 to 3 hours a week in extra time that I can spend more with my patients and more with my family. And so he became one of our advocates. But take a data-driven approach, but combine that with stories that drive home the importance of that data. Shafiq?
Yeah, so I think I'll make it very succinct. One, when I got to any institution, I put the cleaning solution outside, and I changed the name of the IT department as a clinical department. That's anecdotal. So everybody, when like you go to the OR or into any patient's room, you have to wash your hands. Everybody did that. Second is that what happens to us, we say governance, we think IT is the boss. That has to change. So the reason it succeeds if there is an operational leader owns it, because we are serving them, and that operational leader needs a clinical leader to support it. They have to be aligned. IT becomes the third leg, and the fourth is the customer where we are. So institutions where you will see success, you have an executive sponsor. And that sponsor either is an operational leader or is a clinical leader. So it's kind of important for us to understand that if you are talking about, like, why is a router important? Why is a controller important? Why is Wi-Fi reliability important? Why is texting important? So these are all have clinical implications. In the olden days, they did not. And here's the part that is very important. The advent of AI and using of the predictability models, we need the answer like that. So if you need the answer like that, you have to have speed and you have to have reliability. You're sitting in a room and try to read a mammogram and try to talk to the lady, try to show it to her that what is this. You can't have a long, you can't have that. You just can't have that. So that is why when you ask the question, what is the secret of the success? So the secret of the success is that you also have to have a healthy respect for each other. I love my CMIO who works with me now. I still love Rab and Patty. When I see each other, we smile each other, we give each other a hug. So what I'm trying to tell you is that personal relationship is also important. And because we are all trying to do the same thing. So when you're talking about ego and all that. Leave it outside, because the reason we are doing all of this for what? And the answer I'll give you in one sentence. If my mother comes for help in that institution, I want to have her the best care. If my child comes to the institution or outside for care, I want him or her to be treated in a lickety split. You see that? So when we bonded or when we are working, we are thinking that the place we work and the things we are doing, we're not doing for strangers. These are our community members. These are the people who rely on us. So that emotional touch and that understanding is the melding of the heart. Of course, we all have PhDs and MDs and RN and BSN, and we are all clinical AI, this and that. But what is the real reason? That's the real reason healthcare institutions are there. And I did mention ROI because that is very important in this day and age, because you have to understand finances and you have to understand how to do things in a smarter way. And the part that I learned is that the doctors and nurses who helped us build this and who benefited from this are our best supporters, our best cheerleaders. So we not only did the work, we also made friends. We not only made friends, we got people to back us up. That's a win, double win for us.
Yeah.
From the CIO, I'm sorry, go ahead, Dr. Patty.
Yeah, getting those clinical leaders to come to the the senior leadership meetings and drive home the importance of the work that we're doing around EHR satisfaction is so critical. It really drives home that the message. Like I said, you need data, but data in and of itself isn't enough. You need those voices of those end users really saying, hey, this is why this is important, because it impacts my care of my patients.
Dr. Patty, when you were giving that story about the orthopedics surgeon, did you intentionally look for, anytime we're trying to drive organizational change and it requires changes in behavior, right? There's always going to be folks that are on board and ones that are not. It sounds like you might have looked for quick wins, right? Or sort of focused on a few people that were held in high regard, possibly vocal, that you could turn around and they helped carry your message.
Well, and that's true, because those early wins help you go back to the finance and the budgeting meetings and saying, here's the impact that investing in this has, and here's a key voice that that the organization is listening to, and this is having an impact, a positive impact on this person. This work is having a positive impact on this person. And that helps drive the point home, and it makes, quite frankly, the budget conversations easier.
And Dr. Rab, when these changes occurred, what sort of changes did you have to make in IT? In one of our conversations leading up to this, you were talking about the foundational elements, the sort of the blocking and tackling in IT, whether it's networks or servers or moving the EHR to the cloud. What are the changes that you had to make?
Well, first of all, I was lucky to have a great team. My team members are perfect, as I tell everybody, but nobody believes it. The thing is that as a leader, like I'm talking to you, you can see that you have to convey and work within your team. What is the purpose? Why are we here? So luckily, it didn't take much convincing to our team. But the biggest thing that happened to our team as they worked, our clinical leaders within our team and our Epic analyst who did the personalization, and the network team and the device team, as they helped people, they got thank yous. So no more people were living in the basement or in the data centers. Actually, they were out and about in the hospital, in the clinics, in the outpatient department. So the value of the work that they are doing they got to see firsthand how it impacted healthcare. That all of a sudden increased their morale. Instead of being beaten down all the time, things are not working, this not working, that's not working, they got thank yous and they got appreciated. So that was the biggest thing that happened, that the team got to raise up. That's one. Changes means is that we have to become smarter. Smarter means is that not help desk calling us, the system is down, not that way. We knew before. So the preemptiveness and predictability making us smarter, that how we can know things before it happens. Third, what it did is that as Dr. Patty and his team and informatics and other clinical informatics, nursing informatics, and the CMO and all of those people did things, we got to do project planning. We did a PMs. So we did things in a structured and organized way instead of doing one-off. Who knows who and what happens when. So instead of doing that, we had to look at it a comprehensive way. So the changes that happened within us, we became more organized. We had a project management team. We did it as a group, and we planned it in a way that it facilitates things that went further. And the reason we succeeded so well, when the pandemic hit, we were ready for it. Think about that. 2-3 years of training, pandemic hits, and we built a 1,000-bed hospital in 3 days. It's the same team. So our team became agile. Our team became adaptable. Our team became phenomenal. So I'm telling you the benefits of that. The changes is that we talked it out. And not only me, my directors, my VPs, and my managers who work with me, they took the lead among themselves to create that force. That's my answer.
Yeah, and the importance of the team is so critical. I know when I was at Rush, I purposely brought in physicians into my team from various workflows, hospitalists, surgeons, ED docs, internists, primary care, pediatricians. Multiple workflows were represented on my team, and I gave them the power to act and gave them the power to do the things that they thought were important within their sphere of influence, and they just did phenomenal work. And so, Shafiq's point about building a strong team is so critical. None of the success we had would we have achieved without the teams that were around us, and really giving those people the latitude to think and act for themselves, and giving them that permission, if you will. And it really helped, the work improved exponentially as our teams became started to work together and started to really engage with the organization and become well known across the organization, because the organization saw them as really impacting the results that we were having.
And at the end of the day, we started talking about burnout. Was that the major driver that gave you the ability to ROI the investment network? I'm imagining there was an investment necessary to make some of take some of the actions, whether it's additional training or infrastructure, what have you. How did you justify any investment? Was it based primarily on burnout, or were there other factors?
I think there were two kind of key things that the organization, so you have to understand what your organization is paying attention to. You have to talk to the leaders and understand what's important to them. And as Shafiq mentioned, we had a very knowledgeable leadership team, and they were focused on burnout. And so we really said, burnout is causing a huge amount of turnover at our organization. You can see in the lower parts of this slide, but when we started this project, physician turnover at our organization was at 12% per year. That's a lot of recruiting and training of new physicians that the organization was having to do because burnout and EHR satisfaction were driving people out of the organization. And so it happened that burnout was the thing that the organization was paying attention to, and that's where we kind of said, okay, this program is going to impact burnout in this way, and we can measure it, and we will measure it, and we'll come back to you and show you the results. And we had both quick wins and long-term wins that we were measuring. And so that was what was important in our organization. That's what drove the budgeting process, if you will. But you have to understand what the drivers are at your organization. Burnout is oftentimes a key driver. It may not be. You have to understand those levers. And so the two big levers for us were burnout, EHR, or the three big levers were burnout and associated, EHR satisfaction and the associated burnout, and then physician turnover. And you can see we improved both of those exponentially. We went from being in the 45th percentile in the Class Arch Collaborative to 2 years later being in the 99th percentile. And over that same period of time, physician turnover went from 12% down to 6% per year. And so, we had a huge impact on the organization. We were able to communicate that because we were proactively measuring ahead of time and then throughout the process.
Dr. Rab, your thoughts?
I concur with what Dr. Patty said. Most important thing for any one of us who are in this business to understand the mission, the vision, the goals, and the strategic objectives of the institution. Our job is to align with it. And at that time, this was very important. And everybody has to play a role. Fortunately, me and Brian were lucky that we liked each other. And we got together and we believed in it. And fortunately, our teams got together. And fortunately, Brian has a huge team of informatics people. They all got together, and then we got the support from our leaders. So we became successful. And at that time, our class was just starting this thing. So we became one of the few. And we dedicated time. And as you can see from the result speaks for itself. That's not that we made it up or wrote something. So that means there was a problem, and we did something about it. And not only EHR speed and reliability, but we also did training, we did education, we did personalization, and we helped the user settings. So this is all part of IT. There's infrastructure IT, and there's electronic health record IT and EHR IT. So to work collaboratively among ourselves too. Like if there's an Epic analyst, he's calling his buddy who does the end user training. He's calling his buddy who's doing the end user setting. So the team became stronger working together. So these are all byproducts, but the drivers that you said is very important for anybody in our job is to align yourself to the institutional needs.
So the last 10 minutes have been questions from the audience. I didn't break it, announce it, but they've been asking you their questions. So we have a couple of minutes left, maybe a quick lightning round. Dr. Rab, from a CIO's perspective, what are the things that CIOs in healthcare should be looking at over the next 3 years and 3 to 5 years? And Dr. Patty, the same will come to you for the CMIOs.
Number one, mission, vision, and alignment. Whichever institution you work, you have to align yourself to the institution. Each institution is trying to grow. They're trying to improve their bottom line. They're also trying to improve their services. Access is a big deal. Everybody's working on it. So in the next 3 to 4 years, the whole country is going to struggle with it. While you are struggling with it and trying to do that, all your operational leaders are looking to you as one of their friends to guide them. That means your CEO, your CFO, your other people are looking to you. So become a partner, become a friend to the C-suite, and communicate. Like, for example, some of us go and learn what to do budget. Our job is to share what AI is, to share what other technologies are. So our other colleagues are as knowledgeable, if not more knowledgeable than us. So when the time comes to make decisions, we should have those things common between us. It's not a fight, it's a collaboration, it's working. Third is that while you're doing all of this, if you have an EHR, they do provide AI things. If you have an ERP, they are doing it. Don't lose it. That means that don't go after a shiny object, but go after the ones that will give you 4 times, 5 times ROI. Do denial management, do ambience. So what I'm saying to you is that don't miss that opportunity. And the people who work for you, allow them to grow. Because if you don't allow them to grow, they will leave. Or they need to learn new things. And lastly, do not forget the worst enemy in the world, cybersecurity. You cannot forget them. They are the worst of the worst, you know, and that is a threat that we all deal with it in every day. And the last word, which was not the last word, last one, is that we are here to serve our patients and to serve up the people who have given everything and come in the most vulnerable way to us. So as an institution, our job is to support our caregivers and to support our staff so they feel loved and liked and appreciated by us so that they can do their jobs in the best possible way. This is not a difficult job, but it is the most important job to be that colleague, that friend to the rest of the institution. And don't forget the AI rush, but do not go for the shining object, but go for the benefit of it. Dr. Patty.
Yeah, I mean, I'll echo the point of aligning yourself with the mission, vision, and values of the organization. Understand what the strategies are, understand what the key projects are. Align your work with the things that are driving your organization. When I go into an organization, I do 3 things. I look at data. I like to use the Class Arch Collaborative Survey. I'll look at Epic, the data within Epic. I will then also look at, you know, the configuration of the EHR and what that's looking like. And then the third thing I do is talk to leaders, talk to clinical leaders, talk to operational leaders, understand what's important, what's driving them, what are the things that they're trying to solve. And then I'll come up with recommendations for the key projects that the organization needs to do going forward. You know, so looking at those data sets, looking at some measurement with Arch Collaborative or somebody else, looking at Epic data, and then looking at the voice of the leadership and what's driving them and what are the things that they're trying to solve, and align the strategy going forward with those solving those 3 things.
Well, gentlemen, doctors, thank you so much for your time, and we appreciate it. I'm sure the audience appreciates it, and congratulations on your collective success. So thank you for joining.
Thank you for having us.
All right. Take care. Thank you.